And welcome back to the simplyendo podcast. I'm Dave Baker, and I'm here as always with Rob Masters. Good to catch up, Rob. It's January, start of a new year.
Very much so, my friend. Very much.
Yeah.
Good
Did you have a good
up.
Christmas and everything?
Very nice. Yeah, really good. Lovely,
Yeah.
actually.
It just goes so quick, doesn't it? I don't know how long you're supposed to say Happy New Year to people for.
Yeah, definitely. Definitely.
When
with
is there a cut-off point?
I personally think after like the first full week of work.
Yeah.
So we went back on the Friday, didn't we, this year? So I was Happy New Year in all the following week, and then I kind of stopped, unless the patient said it to me.
Yes, because then it's like March and they're coming in saying Happy New Year.
Yeah.
And then what will happen is patients, if you're seeing regular patients, they will say, I'll see you in 6 months' time, which means you'll see them then in June, July. And then when they leave the room, they'll say, have a good Christmas.
Yes. I always get wished Merry Christmas in July. And they always think it's funny, and then the first one I go, you're about the 7th today, but yeah. Oh yeah, that's a good one.
Christmas.
It's like, that's like the radiograph joke, isn't it? You know, they go, oh, it scares me when you run off, when you go, and you go, do you know what, I've never heard that before.
Yeah, when you run out the room.
Yeah. And that's what I always say, I say, look, the problem is if we leg it.
Don't come back.
You're in trouble there.
Don't come back. Yeah,
if we walk past into the the safe area and press a button, you're fine. But if we leg it, you're in trouble. Or you find you're in here on your own.
But you see, that also comes with the things patients say. Knee on the chest. Yeah.
Do you know what?
Have you ever tried it?
Yeah,
I've never put my knee on anyone's chest.
Because me and
you had a go?
Yeah, and obviously I'm not the most flexible, but I would have been. I couldn't I'd be in agony.
You hang on, just rewind a minute. When I said you tried it on a patient.
No. As in, because I was saying to the nurse that this is ridiculous.
Yep.
So we tried to get.
You tried to recreate.
Yeah, so we got
one
one of the other dentists to come and sit in the chair,
Yeah.
and then I tried to put my knee on their chest. It just looked like there was something wrong with me. I think I fell over. So you wouldn't take a tooth out.
I think it's the leaning over people, isn't it? Though. But yeah.
But I'm convinced what happens is they believe it, because I think over the time the story gets exaggerated, doesn't it? And then they just end up convinced he had his knee on my chest.
Yeah.
Where it's probably just a trick.
I remember seeing a thing about that, and it was something, I don't know, it could have been Jeremy Kyle or something along those lines, and it was where people had lie detector tests, and they'd got to the point where they believed the lie detector test so much that the lie detector test was kind of saying he's lying, but he does believe himself, if that makes sense, and it was hard to prove it otherwise. So, I've never seen anybody do it, the knee on the chest thing. But yeah, there are things people say. But new year, new start, new endo program.
Yeah.
So we've got our 10-day program, which has just started in London, which is always good fun, and quite exciting. I know you get excited because you like London.
I love London.
What do you love most about London?
I love the bustle of it. I love you can do pretty much anything you want. I just think it's exciting. Lovely restaurants. Museum, you name it, you can do it.
So I did ask you this briefly yesterday. I don't know. It was more a question of where would you live. So I was lucky enough, as I said to you, I went to New York at Christmas, which was amazing. Very cold, but amazing. Definitely a bucket list thing to do. Maybe not somewhere to live forever, but somewhere to go. New York or London.
I don't know. I mean, if you said I'd got to live somewhere tomorrow, London hands down.
Really?
But I've always said that when time allows it, I want to go and rent a flat in New York for like 2-3 months and just kind of live there, and just because when you go, you're there for like 4 or 5 days, and it's mental, and you're trying to get here, there, and everywhere, and I just want to live there, soak it all up. Because I love New York as well. I absolutely love it, but I suppose I'm just more familiar with London.
Funny, isn't it? I loved it. I thought it was fantastic. I just thought it was obviously it was Christmas time, so it was mental. There was lots of people all going in different directions. There were bits of it I didn't love, because there's like a pleasant unpleasantness about them. If that makes sense. The kind of the politest unpolite people you could meet. They're sort of not deliberately horrible. It's just almost like they want to take your order for coffee, and then they've got things to do.
Yeah.
you know. But yeah, we had a great time and it was good. The kids loved it, and seeing all the Rockefeller and those sort of things was definitely bucket list. Moving forward then, this year ahead, obviously we've got lots of good plans with Simply Endo and our podcasts to keep going. And this time we've got Rob Eades on the podcast. And Rob Eades is someone that was in... I didn't really teach Rob at Simply Endo, which is a shame really, because I didn't get the chance to meet him really. It was only after he'd finished that I become familiar with him because of his stuff he posts a bit on Instagram and stuff. He's obviously had some connections with our forum and stuff as well. But you knew Rob at Formby and stuff, didn't you?
Yeah, no, well, yeah, very lucky to teach him and be part of the groups he was, and yeah, he was just a great guy. Just had so much enthusiasm, and you could tell he knew his stuff, and he was passionate and he cared and he did loads of reading. And yeah, it's just a great guy to have on the course.
Yeah. So this podcast is Rob Eades and talking all things about Rob's career and stuff, all things endo, and his big interest in lasers.
Yeah.
Now I knew very little about lasers before the podcast. He was good fun because you could, and I mean this in the polite way, you could sort of wind him up and let him go, and he just embraced us with everything laser wise, didn't he?
Oh no, he's such a great guy. Yeah.
So hopefully those of you out there enjoy listening to our podcast coming up with Rob Eades. Do keep in touch. Get in touch with us if you've got any ideas for future podcasts or people that you think might be good and keen to come on our podcast. We're always keen to look out for people. We do have exciting things coming up. Take a listen and we'll see you soon.
Very excited to have one of our Simply Endo alumni with us, Rob Eades. I know Rob very well because I did quite a lot of the course with you, didn't I, mate?
You did?
Took you through.
I was amazed he came back, to be honest. I just said that.
Amazed he came back, went through with you, and always admired your enthusiasm. So just really interested, Rob, to obviously, I want you to introduce yourself in a little bit so everyone can know who you are, but also what have you been doing, how you found Simply Endo, what you've been doing since Simply Endo, but also, we know you're using the water lays, and just really excited, want to hear loads about that. So, yeah, over to you, Rob. If you could just do a bit of a brief intro, no pressure, obviously.
No problem at all. So I qualified from Leeds Unit in 2006. I've always been quite keen on education, so I did my MJDF in 2008. I did a diploma in restorative dentistry with the Royal College of Surgeons from 2009 till 2011. And I did the specialist interest modules in endo there. And I was actually really fortunate because I had Stanj Bandari as my tutor for that. So he was actually very up to date in the 2010, era. I then bought a dental practice, or two practices, and merged them into one. Had a son, and then had a daughter, so not a lot of education basically happened. And then basically after about 10 years, I was itching to basically, get back into some academics and, start, actually, I was wanting to do more endo, but I was also slightly apprehensive that my endo might be starting to get a little bit out of date as well, because obviously I'd been taught in 2011, and it was what now, it's like 2020-ish or so. I thought I was quite reasonable at it, but obviously my knowledge base was a little bit lower. And obviously when you studying it, you get that instant knowledge where you can remember references, and you can back up basically what you're saying. So I ummed and ahed, and then we went into COVID, which was not the best times in terms of education stuff. So I thought, all right, well, I'll wait a little bit longer. And then we seemed to be easing off again. I thought, right, do you know what? So I think I started the Simply Endo program in 2021, and it all went better. And then we went back into lockdown again, and it was like, oh, this is not ideal. So my first my module 1 of the 10-day was with Rob online, and the second day was with Mike T online as well. And then it eased off a little bit, and I've got a VW camper van. So basically, I think am I still the only person that slept at the Simply Endo? So I came over on an evening slept in the car park of Simply Endo, went and did basically a nice study day with you guys, and then headed off basically to a campsite on the beach, which I have to say is absolutely like phenomenal. Now, I also found that actually as the course progressed, I found that actually my time, because we obviously finish a little bit earlier at Simply Endo in terms of getting off, I was like, this is like prime essay time. So I actually quite like working with multiple screens. So I'd arrive at the campsite, set up my camper van with like monitors inside it, and literally just crack on. But honestly, whoever else is on that campsite must be thinking, what on earth is this like guy doing inside, like, you know, some form of like secret agent or something. But yeah, it was so cool. So I do some work, then I go for a run on the beach, go get fish and chips, then do some more work and stuff. But it's amazing. I really do miss coming to see you guys. So the program is amazing.
Rob, I've just got to ask this. You bought 2 practices.
I did, yeah. So we actually there was 2 practices in the town. One was for sale, and there was another NHS practice that was, the chap who was getting a little bit more close to retirement. So I kind of just sounded him out. But he actually was in a leasehold premises there was no need to continue the lease either. So literally I ended up buying the private practice. And we also bought the NHS practice. Now, we actually completely converted the practice to fully private just after we came out the back of COVID, and that was amazing. That was it was a bit nerve wracking, but it was actually a really good decision. It's helped the practice move forwards. It's meant that basically we can start, some more serious investments in technology and things, which is ace. We've also become a lot more it's like single disciplines within the practice. Like we've got one of my dentists, Colette, she's very much into her Invisalign and things. We've got Maria, who's basically massively into her oral surgery. So she does a lot of implant work, a lot of extractions. She actually does quite a lot of perio with the laser as well. And that was actually the reason for buying the laser. And the laser got bought on a bit of a whim for my associate. And as it happens, actually, I use it far more than she does now. But yeah, we've got a nice knit team of basically different. We all do general, but we've all got our own little niches as well, which is quite nice. So I've done a bit of fast track ortho in the past, for example, but it really doesn't float my boat. So I am more than happy to pass that across to another dentist who enjoys doing it. So I think that setup works really well.
So how's your week broken up then, Rob, in terms of like endo referrals and then your general stuff?
Yeah, so I mean, the way I've had the practice since 2011. So I used to be, initially we bought the practice, and the practice was actually a 3-day-a-week private practice. So the intention was basically when I bought it, I just finished my restorative diploma. I thought, this is fantastic. I've got 3 days worth of patients, which I can do normal stuff, and I'll start pushing a bit of referral work on the other 2 days. The day that we took it over, I went to 5 days flat out, like literally, just on normal. And it's taken that long to basically then start dividing it up and moving it, to the other clinicians and things. So how I work now, I tend to have my diehard patient group. So the ones that got the note on that only want to see Robs. So that's my patient cohort that I look after for their general care. I do all the endo for the practice. So basically that gets filtered through. And I do quite a lot of referral work as well. So I've got a few key local practices that send me quite a lot of work, and it's something I want to do more of. It's just balance. But you're right, though. It's hard. It's balancing your time, isn't it? Because actually, I'm not fast at endo. I'm always still going to take me 2 hours and probably 2.5 hour appointment by the time I've done, chatting either side of it. So there's not actually that many of those in a working day. So it is tricky balancing up, And obviously I want to spend time with kids and things as well, so I don't want to be just at work all the time as well. But yeah, the balance is good. It's good.
We've both been in the same position as Rob. My week sounds very much like you, and I do have those hardcore patients who, they've followed me from a couple of practices until we bought our own, and then you kind of think, it's a bit cruel now to say, well, they're only seeing the associates. Some of them are happy enough because they feel, Dave's still there, but I'm the same as you, so I have a little morning of kind of general stuff, and the rest is kind of referral endo. But it is hard to try and it's quite brave as well, isn't it? You enjoy the endo stuff, but then equally you don't want to leave some of the other stuff behind. Perhaps I could quite happily leave dentures though. I think I've decided the odd one. We had one the other day where there's a lady who, you made the last one for me 10 years ago, and I thought, yeah, but I don't want to make the next one, So Yeah, I think it's quite a balance, really, isn't it? So,
No, it's
Rob, can I go back a fraction then? Because somebody said something about you the other day, which was a really good compliment, and it was to do with when you were on the Simply Endo course, that often people would, they asked the tutors, which is great, but it was, if Rob Eades was there, they'd often ask Rob Eades as well, which sounded really impressive. So, were you like a high flyer at dental school, would you say, or did you just sail through, or what? Did you struggle, or what?
It depends on what you mean by high flyer. So, can I do it? Yes. So in terms of my like educational career, went through GCSEs, got really good grades, like literally not even a problem. Cruised into A level thinking that was going to happen for me. Thank goodness that basically our chemistry was a modular exam, so like 6 exams over the 2-year period. Because I sat the exam, oh yeah, I'll be fine. I'm really good at science. You know what came back? A D for devastation. I was like, oh my goodness, I've never got a D in science in my life, honestly. So I absolutely like worked my socks off for the rest of the A-level year. All your friends are like, oh, you're coming down to the pub, Rob? No, actually, I was in my bedroom with mind maps all over the place. So I think in terms of like, I've got quite an engineering background. So like, I don't think I'm textbook bright, i.e. like I read a textbook and I can just remember it. But if you give me a problem to work out, then once I've got the knowledge and it's all clicked together, I think I am good at that type of thing. I do quite a lot of engineering at home. I don't know if I've ever showed you, Rob, but like I can weld and I can use a lathe and I can use a milling machine and I make some quite fancy car parts. But again, it's all self-taught, but it's all part of the same mechanical brain a little bit. So am I the brightest person at uni? Definitely not. I did do well at uni. I mean, to be fair, I got honours in my degree because I worked my absolute socks off, to be fair. But yeah, I don't think I'm like textbook bright though, if you know what I mean. Like I have to work at it to basically get the knowledge. But once it clicks, I understand it. It's not a photographic thing. It's actually more of a deeper understanding and how it's all working and how to problem solve that information. It's one of the major things actually I found on the restorative diploma, because that was the restorative diploma was set over 2 years. Phenomenally difficult program, I'll be honest. Like literally, I'm not even sure. I know they toned it down, but at the time it was just crazy because literally you turned up, you had an evening where it was a study evening, and you went through cases. So basically, you brought face bows and what you were planning to do. On the Friday, you handed an essay in, which you'd been given the month before to write. So every single study day had an essay to hand in. You had an exam to do on the Friday morning before the study day. Now, Paul Brunt, I was fortunate enough to have Paul Brunton as one of the tutors for that. And he was a great believer in actually having the exam paper a few days before the actual exam. So basically, i.e. the quality of your answers is going to be much higher if you've been given the exam paper before. So these exams didn't actually count towards the final degree. You got examinations at the end of it, but it meant that basically you had to sit down, you had to be able to reference things and to write things. We then had a study day for the rest of the day, and then as an overall thing, you had your main exams, your OSCEs, and your MCQs and your writtens, I think, at the end. But you had to do 10 major cases and 20 minor cases, and these are like full mouth rehab cases, like crazy stuff. But actually, they've taken like 18 months to get from start to finish. So what an amazing program! Could I do it nowadays with a business and kids? Absolutely not. To be fair, definitely not. But it brought everything together really well, because like literally you turned up with these multidisciplinary cases that have got endo, they've got restorative, they've got perio, they've got occlusional issues, and you had to be able to put that together. So I did really well in that course, which was fantastic. As I say, I had 10 years gap with business, kids, etc., itching to basically get myself back up to date again in terms of, hey, I want to do a bit more referral work, but I don't know if I've got the confidence to do it. Like, am I still up to date? Can I do with the job, etc.? So I came on with you guys. Simply Endo's course, absolutely amazing in terms of, and actually, I think more actually for me that I found with the Simply Endo course, not necessarily sometimes not the content, because actually I think Sanj Bandari's teaching in 2009, 2010, 2011 was really up to date then. So yes, some of the technology's changed in terms of the metals we use in NITI. We have developed quite significantly, I think, in the bioceramics in that time period. And that is one thing that I've taken from Simply Endo. I use MTA and all the MTA derivatives an awful lot more for apexification and things like that than I ever ever had. And same with pulp capping and things. So I am much more confident with that aspect of dentistry since doing Simply Endo. But actually, a lot of it was coming on the day courses and actually chatting to you guys and actually bringing a case that's pretty complicated or just a bit out of your comfort zone and having a chat through and actually deciding basically what, which way you go. And even if it's just, yeah, Rob, that sounds fine, and I'd crack on with it. That is so helpful to have, a set of mentors. And I think that's another issue actually a little bit about being the practice principal, in that I'm really happy to mentor all the associates and the nurses that work with me. But it's quite hard sometimes being the principal because you don't really have that person, that's going to mentor you.
Who do you ask for? Yeah, it's true.
It's really, really tricky, especially if it's endo, because actually they're sending their endos to you in the first place. So it is a little bit of an isolated world. So did finish the MSc with you guys, and then started doing a little bit more other bits. So we had a dentist join us, Maria, and Maria had used the laser quite a bit for perio. And she's like, Maria's lovely. She's Spanish, and literally she's like raving about how amazing this laser is. And on a bit of a whim, I did quite a lot of research on it because I do like to read about things. There's still not loads of evidence base for it. So I'm like, in an hour. And anyway, so basically we thought, right, do you know what? We're going to take the plunge. We're going to buy the laser. So, we didn't just buy one laser. We got two lasers. We got the water laser, which is an erbium chromium YSGG, and we also got a diode laser as well. And then obviously the training then starts, and that's the hardest bit about the laser, in that you get taught absolutely nothing about it at any point of your career. Like, in terms of, you might learn a little bit about diode and how that cuts stuff. Oh my goodness, it's so much bigger than that. It's a whole topic in itself. So I did some extra training with the laser, as you can imagine, and I've you do like an entrance exam into the World Clinical Laser Institute, so the WCLI. So I'm now an associate fellow with them. You can then do some like case presentation stuff with them and sit like another little exam, and then you become a fellow. And then if you want to take it a little bit further, you can become a master with the WCLI. And at the same time as that, Coltine got quite interested in working with me as well. So Coltine took me out to Switzerland, because I know you guys have done this as well, haven't you?
Yeah.
So that happened last year. So that was an amazing trip as well. So I'm actually doing a bit of teaching with Coltine next month, which is really a massive privilege and really cool. So we're actually going to be teaching a bit of high flex, but also the new OGSF as well, because that's a really nice bit of kit.
So what you're using day to day, Rob, high flex OGS and OGS?
Yeah, to be honest, Rob, I just like the high flex complete system. I find it ticks most box. I do have other bits and pieces. I just find it ticks most boxes for me. And actually, like, if I want a 4004 or a 6002, or it kind of works well with the mechanical part of my brain. It just says what it is. Do you know what I mean? On the label, I don't have to work out what an F2 or an S3. Do you know what I mean? It is just basically that size. And I do like it. The OGSF, I've got a huge, I don't know if you know, but Coltine quite often basically do really good offers on their high flex file systems. So like do 2 buy 2 get 1 free. So I have like I have a huge order every 6 months where you spend, I don't know, 6-7 grand on files, and they just go in your cupboard, and then you basically deplete it until the next 6 months. Because it does, if you buy it on that offer, they are really quite a cheap system, and I go through quite a lot. I mean, I know they market it as like a 1 file or a 2 file system. I'm going to be honest, I don't tend to use it like that. I tend to have multiple different sizes. If it's an upper molar, I might have, if it's original high flex, I might have a 1 file 25, I might have a 2005, there might be a 5002 mixed in there. The Vista buckle's a bit big, so that needs to be a 4004. So actually, all of a sudden, it's not a 1 file system, because it just had to be, all the canals are different sizes. So literally, you need different files.
Do you use it with the Jenny motor?
I do. That is an awesome bit of kit as well. Yeah, really good bit of kit. I've never actually fractured a high flex file with using Jenny, and I've done some quite complicated. I'm careful with it, and again, I'm probably slightly overcautious in that. If I think a file has worked very hard, I have the opinion it's going to upset me an awful lot more if I fracture that file than it will be just putting it in the bin and getting a brand new one out.
Yeah.
So I just think in the scheme of the cost of things, I just think, do you know what, Rob? And if you think it's going to break, there's a reason why you think it's going to break. You're like, right, but I've never broken one, so I've never pushed it to the limit. But as I say, I'm quite easy at basically binning files, and I was thinking, you know, actually, I'll be very upset with myself later if I do that, or I'm going to waste an awful lot of time basically, you know, doing file retrieval. So because again, you know, I was talking to you guys a little bit just before I went on. I'm trying to target my education now a bit more towards certain people that teach. So I went on Yosh Terryushi's, you know, file retrieval course. That was really fantastic course in terms of concepts there that I hadn't understood in terms of basically getting files out. And you know what? It just works. It's a system. He's a very clever man. He's spent an awful lot of time and an awful lot of energy, you know, working out how to take files out, and he's come up with an actual system. Basically, it's a bit of a recipe for doing it. I did Sandra's. Have you heard of Sandra's cadaver course? Another one that he does for because again, do you know what? Absolutely. I know you guys do an apicectomy course, and obviously it's great, but this is actually on, you know, fresh frozen cadavers. So you get like, I don't know, 2 years worth of, you know, apical surgery experience in a day. So that was a phenomenal course as well. So that's kind of where I'm going a little bit in terms of, you know, direction for education, trying to target these, you know, these people that I want to learn from. I've got Antonio Shaniotis' canal blockage course coming up in February. That's in Athens. So that's something to look forward to. And obviously I'm starting to do quite a bit with the lasers. The laser conferences are actually quite worldwide, but they do hold quite a lot they're never in the UK. To be fair, they're never in the UK. But I went out to Lisbon last year. Well, I went to two places actually. I went to Lisbon for like a conference, and then I went to Munich for a few days to basically get my like basic laser training done, which was awesome. I have to say that the basic laser training, which was a 3-day course, I have never had so much content trying to put in my brain in 3 days. I came away from that course absolutely like mind fried, to the point where actually I've had a chat with BioLaser. I'd actually like you can go back on the same course again at like a really reduced rate. Do you know? And I just feel like now that you kind of need. I'd love to go do that again and listen to all the speakers again. Because the problem with the laser is basically you can buy this piece of equipment, but you've absolutely no experience of it whatsoever. Like, you don't understand any of the physics that are involved. You don't understand any of, like, you know, how it's going to work, what functions it's got. So I do get why quite a lot of lasers get bought in dental practices and they get put in a corner and they gather dust. Because unless you're willing to purchase the thing in the first place, but also more importantly, actually, you know, spend the time, you know, learning actually what it's good at, what it's not so good at, and, you know, what the applications are. But actually, it's not a very good piece of equipment, because actually you just don't know how to get the best out of it. So that's kind of where I'm at the minute in terms of bits and bats. It'd be nice to come and see you guys again, hopefully soon.
Yeah, definitely. Fantastic. Gosh, you mentioned so many things I wanted to talk about there, Rob. Because can I go with lasers? Is that all right?
Yeah, definitely.
If I ask you a little bit about the lasers, as somebody who doesn't know a great deal about them, so obviously I've seen some of the stuff you do with it. Lasers to me sometimes sound like, do you ever remember the old Dremel advert where it says Dremel does this and Dremel does that and Dremel, and then it was a hammer and it went, oh yeah, did we mention Dremel cuts? I get the feeling with the lasers, there's an awful lot of applications now. We had a little look at one of that was a water lathe, wasn't it? But it was, the guy came in and basically showed us how it could clean a penny. And I thought, well, I'm not cleaning many pennies in the practice, to be fair. I'd like a few more, but I'm not cleaning many. So tell me about the sort of lathes that you use predominantly, what it actually is, and then the applications that you use it for, maybe related to endo.
Yeah, so I think the biggest issue with laser, and there's a lecturer that called Isaac from Mexico that goes through, is the term laser. It's a little bit like using the term medicine. Yeah. In that, I'm going to fix this problem. How are you going to fix it? Well, I'm going to use medicine. And it's just not very specific to a problem whatsoever. Okay. Yeah. So the whole thing about laser is basically about what you're trying to, achieve with it. So the actual laser is light amplification by stimulated emission of radiation. Okay. So in terms of what's happening, you effectively have some form of crystal or some form of diode that basically you excite basically the whatever's inside the medium that's inside there. It causes a higher electron state, and because those electrons then drop down, you get a photon release. Now, generally what happens is you have two mirrors, and basically those photons bounce backwards and forwards, backwards and forwards, backwards and forwards, and become concentrated. Now, the thing that's very important about lasers is that basically they are one wavelength. So rather than a light bulb, if you get a 60-watt light bulb and shine it in a patient's mouth, it just lights the patient's mouth up. It has no actual real interaction. Whereas the way that a laser works is because it's producing a single wavelength, all of the energies are also coherent as well. So basically all of the waves are actually in line with each other. So rather than having this random interaction where a light bulb's just giving lots of wavelengths out, lots of different, sync, they're all not in sync anymore, you can't do an awful lot with it. So how the laser works, it depends on, and it's also collimated as well. So it's concentrated. So when the laser energy comes out, you've got a laser of a very specific wavelength. So a diode laser is 940 nanometers, whereas the water laser is coming out at 2780 nanometers. And that massively changes about what it's going to interact with. So a diode laser, it will only really interact with things that have got pigmentation in them. So if you're going to basically use something that's got, as I say, pigment to it, you can interact with it. So hemoglobin, melanin. So you can cut with a diode laser. Now, interestingly, when you cut with a diode laser, you actually initiate the tip. So you get some articulating paper and you basically burn onto the end of the actual tip. So actually, it's not fully working as a laser. It's basically a very, very hot tip that basically removes a tissue, but you get amazing hemostasis with it because it's coagulating at the same time. So that's one application of the diode laser.
So is that something, sorry, go on, I've interrupted you, but yeah. I just want to ask, is that so this is something you're going to do on soft tissue where you can, if there's, a gingival margin that's come over or, gingiva's grown into a cavity or something, you could use this to tidy it all up very neatly?
Absolutely. So you can use it for troughing. So like if you're doing a crown prep, you can trough a little bit of a margin out, but you're absolutely right. So I quite often, if there's a bit of subgingival caries, you can just very carefully take away the tissue. But because it's not like the electrosurgery, which massively cauterize, like it leaves quite a mess, doesn't it? Whereas the laser is very specific and it doesn't bleed. So actually it's really, really good for basically moisture control, especially with, all the adhesive work. Now, you can also do things like frenectomies or, like polyp removals and things with the diode. Now, however, the diode, I think, and this is a completely new area for me, is about what happens when that energy gets absorbed by the tissue and then actually goes into the tissue, because you actually get something called photobiomodulation, which is actually not something I'd heard of at all until basically using lasers. So photobiomodulation has huge influence basically on the tissues. So it increases vascularity, it increases beta endorphin releases, it stimulates ATP metabolism. You get increased fibroblast and osteoblast function. You get an increased immune response. You definitely get decreased inflammation. And I've had some cracking cases where Maria has done surgical wisdom teeth patients. The patients come in, they can get one digit in between the teeth. I've done a little bit of laser therapy on the jaws, and all of a sudden they're 2.5 digits. And all I've done is run a laser across the side of the face, and it's just it actually, to be fair, it's blown my mind a little bit as this. So the photobiomodulation stuff is just it's one application of the diode that basically I have no idea about.
So obviously it's very different cut, so has it got different strengths and bits? Because you said it's very concentrated, didn't you? So
yeah,
I forget what the nanometers was it, but what's the difference between creating running it over the soft tissue to reduce inflammation or cutting the tissue? So
it's tip. So if you want to cut with it, you initiate the tip. So you basically burn in it on the edge of the tip, a darkened area. So if you actually didn't touch the soft tissues with it, you'd burn the tip out because it will glow, like it gets absolutely red hot. Whereas if you're doing photobiomodulation, use a non-initiated tip, so that laser energy is going into the tissues. So if, for example, you're doing extraoral, like, so most of the stuff intraoral is like with a 0.3 of a mil tip, so it's quite a concentrated tip, and you use 1 watt of continuous laser energy to basically, so it's quite, collimated down, and it's quite concentrated. If you're using it for the photobiomodulation around, so I for example, use it, say for that wisdom tooth, you have a bigger handpiece, and that runs 3.5 watts. So there's more wattage, but it's actually over a much bigger area. So it's not, the energy is not concentrated enough that you're actually going to start to cause, cellular damage. If you held it there for long enough, it probably would, but you use it in like continuous motion across basically the skin. On all of my cases, I use the diode laser every single day. So if I'm doing it before, I use it before I give local anesthetic. So if you actually slightly overdose the tissues, you actually get some axial nerve blocks. So if you give local anesthetic, the patient doesn't feel it as much. The patient thinks it's awesome because they're getting laser treatment and it's going in their ear. So they obviously think it's great. They don't feel the local to the same extent, but actually because you've been pushing laser energy, so it's still it's a lower watt, it's half a watt over a centimeter, so it's not a massive amount of dose, it's spread over, but I think you get less tenderness in the tooth afterwards, because again, I've actually preemptively delivered photobiomodulation to the tissues before I've actually done the endo. So that's diode lasers in a nutshell.
So on that, where do you put that then? So if you were doing my lower 6, you're going to give me an ID block, but before doing that, you use the laser. Where do you use the laser then?
On the injection sites. So I do 2 sites. So if it was a block, I'd do ID block site and I'd do the infiltration site. So basically just before doing the local. As I say, can I prove it? No. There might even be an element of placebo there, but patients have definitely returned, and they've actually, I do think they get less. I think they get less soreness. Like you've had an ID. I don't know if you've ever had an ID block yourself.
Yeah, afterwards
I'm sore after an ID block, and it is because the needle. The needle's gone through, and it's inflammation, isn't it, in the tissues? So I find that basically giving the diode, after I've reported it to patients, they've basically said it feels a lot better. You can also use the diode for apical ulceration as well. Now, when we first got it, this is a bit weird because literally you place the laser energy on the area for like 10 seconds. You feel like you're not doing anything. I've had a couple of patients ring the day after and say, Rob, do you know that ulcer? It's so much better from what you did. And I've not prompted that. I mean, patients don't normally get back in touch with the practice unless basically they've got a problem after a treatment, whereas these patients have actually rung to say basically, it's healed up so much better. And so if a patient comes in with an ulcer to a checkup, I definitely will run the diode laser over the top just to accelerate the healing for them.
And can I ask a question, which is not to put you on the spot, so don't please you have to answer exactly, but is there a fee for doing that then? If I came I know that's a difficult question, but I'd probably struggle with that a bit. But
I don't charge for it. I should. But the diode setup. I mean, in fairness, if you're doing photobiomodulation, other than a bit of cling film over the top of the actual handpiece to stop it from potentially going in, there is no cost, and it takes. The diode's been pre-set up. I've signed it off because I'm going to be using it all day anyway. So actually, it takes me 10 seconds to do it. It actually takes longer to get the patient's safety glasses on and the nurse's safety glasses on and the door sign on and the door locked. That's the bit that actually basically takes the biggest amount of time, is basically making sure that it's safe to use.
So you have to lock the door so someone doesn't come in while you're lasering.
Yeah, so basically, this is again the slightly weird bit in that the little tiny diode laser. Have you seen a diode laser before? They're not big machines because diodes are very efficient. Size of a, I don't know. It's small. It's smaller than a laptop. It's tiny. That laser, because it's producing energy that is absorbed by melanin or hemoglobin, that's the biggest risk to the patient, to your eyes, because if you shined it in your eye, it would bypass your lens and it would concentrate on your retina. So that the little tiny laser, weirdly, actually, of the two, is the more dangerous laser. The other thing is the range on it's about 4 meters as well. Now, to actually damage, you are going to get a little bit of reflection, so obviously you need eye protection for that. But obviously, you would never shine it in your eye and turn it on. So yeah, well, actually, to be fair, it is sad this, but there was a lab technician that wasn't sure whether his laser was working, so he did just that. But actually, even the laser, because you do a lot of, as part of the laser regulation stuff, you have to have a laser protection supervisor or a laser protection officer, basically, in your practice. It is very, very similar to radiation, setup. So we have a radiation protection advisor. The same lady is actually our laser protection advisor as well. So there is a bit of legislation stuff that has to go around. It's not particularly arduous, but it has to basically be done right. But there was actually, because you do a lot of laser training, there was a little boy who blinded himself on a laser pointer. Normally, your lasers are all classified depending on how powerful they are. Now, the reason why a laser pointer is normally allowed is because if I shine a laser pointer in your eye, what do? You blink. You blink. You blink. So the thing is that the concentration of energy is not high enough that your blink reflex is actually sufficient to stop it from damaging your eye. This little boy just kept staring at basically the laser, and he blinded himself in the eye. So I think lasers in general can be dangerous. They just have to basically be managed. Now, the water laser, because of basically how it works, the range on that is only between 5 and 10 centimeters. So you do wear protective glasses for it. I mean, I've even put the filter on my microscope. So basically, I've got a 2780 nanometer filter because I'm not taking any chances. But theoretically, there's a very, very low chance that you can actually damage your eyes. And because of the way the water laser works, it's attracted to either water or hydroxyapatite. The energy would actually be dispersed on the surface of your eyeball instead, which actually theoretically would heal, whereas obviously your retina, if you burn a hole in your retina, obviously that's not going to get better. So there is quite a bit with radiation, with the laser safety stuff. It's not particularly arduous, but obviously it has to be taken quite seriously. So yeah, in terms of the door, we put a sign on the door to basically say lasers are in use, and actually we knock the lock down on the door as well. It just stops one of the nurses basically from decon or whatever just shooting through without having protective eyewear on. In fairness, you can take your foot off the pedal. If you hear that door handle go, you'd take your foot off the pedal anyway. But yeah, so there's a couple of bits you have to make sure from a legality perspective. You do need to inform CQC that you're using lasers, for example, as well. There's a little bit of work there, but then again, not particularly arduous. So that's kind of, yeah.
So the diode, in summary, is used for cutting soft tissue.
Yep.
And stimulating healing as well, reducing inflammation. Those are your two main uses for it.
Absolutely. So there is an endodontic protocol that we use in lasers for doing disinfection. Now, I don't actually do this protocol because I still use hypochlorite and I do use EDTA. There are some laser protocols out there for using the water laser to help clean the system, and then you can then use a very fine diode tip down inside the canals using your 940 nanometers, which will get absorbed by pigmented bacteria, and you can kill bacteria with those. There is some research for it. There's a chap in Miguel Martin. He's done a huge amount of work on it, and he's basically he's very clear. I actually met him on the Col team course in Switzerland, and he's very certain that basically this is an acceptable protocol. Personally, for me, I feel medical legally in the UK, if I'm using hypochlorite and I'm using EDTA and I'm using a laser on top, I'm definitely covered in terms of basically, I'm still treating in the remit of what my general profession is treating. So therefore, I think I can without doubt justify that basically what I've done is within, the norm as such.
So how do you use the water lasers? And why did you buy the water lasers? And
But why do we buy the water lasers? Because one of my associates was desperate for one. What do I use the water laser for? So the water laser is completely different to the diode in that it's an all tissue laser. So because the interaction is now with water or with hydroxyapatite. So basically what you call these is chromophores. So the thing that absorbs basically the energy is called a chromophore. So the water laser has a doped crystal that produces that wavelength at one of the peaks for both water and for hydroxyapatite. So if you shine it at something red, it doesn't really do anything. You shine it, if you put it in a glass of water, oh my goodness, the glass of water basically erupts. You get these micro explosions there. So anything that has either of those two things in, you can interact with. So the use is absolutely incredible. So now, if I'm honest, the laser's now part of I've got a high speed, a slow speed, a YSGG laser, and a diode laser. And none of them replace each other, but they are now part and parcel of my, working equipment. So I think it's a little bit like you could use stainless steel files to do a very nice root canal, but all of a sudden you can also use, nickel titanium, and that's going to have a different, benefit as well. So I don't think it's not a necessity to have it, but oh my goodness, it makes the job a lot easier. So things that you can do with the water lathe. So soft tissue interactions, gingival troughing, you can remove any form of soft tissue. But the great bit about your water lathe is that now you've got access to doing hard tissues as well. So I, for example, with the water lathe, I do more crown lengthening surgery than I've done in the last 10 years, to be fair. And the reason for that is it's so easy. So if you get a tooth, and some of the cases I've seen with the water lathe for aesthetic reasons are absolutely out of this world. They are very stable and they produce a fantastic result. I don't use it massively for that. I tend to use it because a tooth's got, there's no ferrule. So I could do with a bit more tooth structure, to wrap around. But all of a sudden, your crown lengthening surgery, you no longer have to do it with a flap. So all you have to do is you basically get your laser tip, you put a little mark on it at 3 millimeters, you chop your gingival tissue basically away to where you need it. You then drop that laser tip down to the 3 millimeter marker, and you basically you start taking it down and you start taking the bone away until you reach that 3 millimeter marker. So all of a sudden you've reestablished your biological width, and you've not needed to raise a flap, and it heals absolutely amazing. So
Rob, just to start that again a little bit. So you use the laser to cut the 3 millimeters of soft tissue.
Well, so as much soft tissue as you want. So basically, all you do is you cut the new semilunar shape out, so that you've got that. You're happy with that, and now, but the problem is that you haven't invaded the biological width, because all we've done is taken away soft tissue. So what you then got is there's a little mark on the laser at 3 millimeters. You pass that into the gingival sulcus, and you can now start taking the bone away.
Right. Okay.
So
and
cool.
How do you know you've removed all the bone and you've done it efficiently?
Because you can see I do it with a microscope. Honestly, it's absolute game changer.
Wow. Right. Okay.
Because you can see down the pocket, because obviously there is now a pocket that you've created, and all you've done is just remove that, that little bit of bone across the top. So yeah, and I do that loads. And actually, even patients, if they come in,
and anterior teeth as well.
Yeah. I mean, obviously, you might have to do the adjacent. Well, I've had a few referral cases where I've said to the patient, "Look, this is a bit dubious. This tooth. I've got two choices. We can leave it as it is. There's not much of a ferrule there. Therefore, this is going to be pushing it. Or you have got a low lip line. Do you mind if basically I take a little bit of the gum away, which is going to give me access to much more tooth? And actually, to be fair, it looks fine. Or it might even be you might be able to get a tiny, you might have a really short clinical crown height on the adjacent tooth anyway." So actually think, do you know what? I can probably get away with a millimeter there anyhow. And you can do both. I mean, there's a big consenting process to it, but the process of doing it, absolute game changer. I've got surgical, we have got surgical piezo and things in the practice as well. And it's just nothing like the laser for doing that. That procedure is just absolutely amazing.
Does that control the hemostasis as well?
Yeah, loads. So absolutely. I mean, you could theoretically prep it and get a new crown on it straight away. I tend to leave it a few weeks, basically, just for it to finally settle down. But the stability of the gingival margin is incredible. Really, really incredible. I saw one of these. There was a chappie on this course in Lisbon. I was mentioned here, and he basically has a gingival mask made up for the patient, which is a dent. He clicks it on, and effectively you can do all of the anterior teeth. And obviously, this is for a different purpose. But he was showing the before and after pictures, and it's incredible. Literally, the gingival margins are exactly where they were planned to be. The predictability is really, really good. So that's kind of what you can use it for externally. If you want to do apical surgery, so much nicer for apical surgery. There's nothing spinning anymore, which I found personally was always the most stressful part of doing apicectomies. So initially I did it with a burr, with a full surgical kit. I then went on to surgical piezo, which is nice. There's nothing wrong with that at all. But the laser, you can use like a 14 millimeter tip or a 17 millimeter. You can actually be mostly out the mouth, so the visibility is incredible. And literally, so you take the gum away from the bone, and literally all you can do is just open that bony window up with the laser. There's the root. You can start easing the root off. You can basically use a curette to get most of the granulation tissue out. If there's anything left, you can use the laser just to quickly vaporize it. And then if you want, you can then you still do your prep with the ultrasonics. So you've got your ultrasonics up inside the canal, but then there's side firing tips, so you can actually pop the laser in and you can direct the laser energy up inside the tooth. And basically that's got disinfection, applications as well. There are some dentists out there that will put a diode laser up inside the actual canal as well, to help disinfect it. So the apical surgery applications are really nice as well.
Well, okay. Did you cut your flap with it then?
You can do, yeah. So I haven't done an apical surgery case just because I do papilla sparing flaps at the minute, and they're quite neat anyway. But you can definitely do your flap. I've seen absolutely loads of flaps done with it. Now the thing about the laser is that you don't get a wound edge, so it won't bleed. So you will get healing by secondary intention, because there isn't actually. So weirdly, when you get a laser wound, it actually looks pretty awful, but actually it heals really well. But because it's cauterized, there's no actual ingress of bacteria, to get into the tissue. But it's different. It is very different. I've seen even like using surgical glue, to put the flap back rather than, because even the suturing, you see, it's not the same as with an actual flap. So I'd also like to put out there as well that literally I've been using a laser a year and a half. I am definitely not an expert in lasers, and I'm still, learning, how to basically adapt it to my treatment things. But exposing roots, for example, say you've got a root that's needs extracting, but it's got bits of tissue above the top of it, just quickly whip that off with a water laser, and you're straight down to the root, and it heals fantastic.
Yeah.
So that's cool.
What about inside the tooth? How are you using it for your orthograde?
Yeah. So in terms of protocol I've got, I'll still access most of my teeth with a high speed, because it's just the laser will definitely do it, but it's slow. And I'm just not sure that I've got the patience to wait to basically get into that. I think the applications for accessing the teeth with it would be really good on anteriors, because you're going to breach the enamel pretty quick and then into dentine. The other things, because of the way it cuts, there's no fractures, because it's ablating the tissue. There's no microfractures within the enamel or the dentine. So for lower incisors, sometimes a bit of enamel chips off, doesn't it, when you access? So I think that would be quite a nice application for it. In terms of an actual endo, I go into the tooth, I flood the pulp chamber with hypochlorite. I still think that's a good idea. There's lots of bugs up there. We might as well kill them off as quickly as we can. I then do something called coronal conditioning. So the laser tips for endo, orthograded endo, are different because they are radial firing tips. So the energy, all the ones I've talked to you about so far, they're all end firing. So the energy comes straight out the end. The radial firing tips, the energy all gets directed out sideways instead, because what we don't want to do is we don't want to cut into into the tooth tissue. We want that energy to go sideways. So we use these radial firing tips inside the pulp chamber, and it's on quite high energy now. So basically you get this popcorn sound, crack, 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 and it just clears out all of the debris on the surface of the canals. I then basically locate the canals. It's a lot easier once you've cleaned it out. I do a little bit of filing, just with a hand file, maybe even just the first third. I'll then quite often go back in with a laser. I'll then do my coronal flaring. So there's nothing new in terms of the endo protocols. All we've done is added the laser in as basically a way of clearing it. Now,
so one thing activating your irrigant with your laser.
Oh, not irrigant, even just water.
Right.
So the coronal conditioning is actually, if you see some of the Instagram videos, the coronal condition throws water everywhere because there's quite a lot of energy there, and it's crack, 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 crack. You actually wouldn't want bleach basically flying around, like that. But what it is doing is it's sending huge shockwaves through the systems. Now, this is one thing that I think the manufacturers for the laser are quite. I don't think they've quite got why the laser's so much better for endo, because quite often you'll see like advertisements, and especially the American stuff is like, well, I can complete cases in one visit now. Well, actually, do you know what? I was completing cases in one visit before I had the laser. That's not a selling point. What is a selling point is that you get into like an MB2 and you can only get in a few millimeters and think, oh geez, that's really tight. If you get the laser and you hover it over the orifice, all of a sudden the file goes to length. And it's like, that's mind blowing.
So what's it doing?
Clearing the debris. Any of the stuff that's in there. Honestly, it's like magic. Like literally, patency is just not an issue. And again, the laser company, I don't think quite realised that actually that for me is the biggest benefit. You just don't get blockages, and if there's even an inherent one because of all the gunk that's inside the tooth, you just don't have issues. Honestly, it's incredible.
So the energy from the laser is, what's it doing to the water? Is it just like the ultrasonic? Is it? It's
So there's more.
Yeah.
So it does cause acoustic streaming, but it's actually causing huge amounts of cavitation. So effectively, when the laser energy goes off, you get the bubble. What's 1,600 times bigger than what it started at. So you're getting this huge bang, 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 bang inside the actual root canal system. So effectively, it's in my mind, it's all the benefits. It's like an ultrasonic on steroids without the issues of a very rigid tip. Now, the other problem with the ultrasonic is that if you've got a really tight orifice into an MB2, you're not going to put an ultrasonic. You can't get an ultrasonic in there. It's just not going to happen. It's not big enough yet. Whereas if you hover the laser over, you are getting that acoustic streaming inside the root canal system, and you've not really even been inside the root canal system yet. So I tend to do that to start with. I'll then do
the gentle wave, even though you're getting it in the top part, it's blasted.
Yeah.
I mean, assuming what they say about gentle wave is true, it's that kind of process, is it?
Yeah, 100%. So actually, interesting, you do take the laser tip down to apex, but you don't get the massive amount of cavity. The acoustic streaming doesn't really occur until you pull the laser tip backwards, and you see that in the mouth. So in terms of protocol, so I go, we've done the coronal flaring, we've found the canals, we've now got patency, size 10. I've now done the prep, I've used OGSF, I've got a 3004. I tend to use continuous irrigation while I'm doing my instrumentation. So there's neat bleach, as the files are working, and I still, wash out between. I'll still do patency filing. If I think there's a lot of debris, I'll pick the laser up again just to basically keep flushing it out. But generally, I'm actually just using water with the laser at that point. Like literally, they're going down inside the canals. I'm making sure the laser's not binding and basically withdrawing it as we come out. Now, the laser you can ledge with, and there is some evidence on that. But when you put the laser tip inside the tooth, you only activate on withdrawal. So you never put the laser tip on, and you never turn the laser on and go into the canal. So we've done all the prep. My final irrigation protocol, basically with the laser, is sodium hypochlorite. The laser. Oh, sorry. Before we go back, I do a water run. So basically, right down to apex, the water laser's only using water, and you just very gradually bring it back, and you can see all the debris basically flying out. And it's incredible actually how much debris comes out, especially if you're recording it with a microscope on the camera. You can actually see the bits coming out when you slow it down. Once I've done that, it gets flooded with sodium hypochlorite. I then go maybe about halfway into the canal and start backing it up. So that's now basically acoustic streaming with the hypochlorite. I then wash it back out with water again with the laser. EDTA goes in the canal, activate that, wash it out with water, and then we basically seal. So that's my protocol for at the minute that I use. Now, this isn't set in stone because actually there are loads of different protocols out there for water laser endo. It's just the one that kind of sits easily with me in that I just think it's a more advanced version of what I was already doing, which I feel comfortable with that.
And so, Rob, you just said about your continuous irrigation.
Yep.
So just talk us through how you're doing that.
Yeah, so in terms of during filing, I always make sure that I've done a really quite a decent pre-endo build-up. So there's always a massive well of sodium hypochlorite in my tooth. I would never, do it with it, flush with the tissues. In terms of actual continuation, obviously there's a lot of exchanges over. I'm just starting to get to the point where I'm going to get the nurses to start injecting at the same time as using the laser. Now, the way of doing that is you put a bend on your needle that's not sufficient to go inside the canal. So it can only reach inside the pulp chamber. So you're not going to get a nurse, accidentally blocking it or locking it into the actual canal. And they basically inject hypochlorite the same time they're sucking it out, the same time that the laser is basically acoustically streaming it. So obviously the fluid volume that you can put through the system then is obviously really high.
Wow.
So it's quite cool. So other thing about the laser as well, patency. There are the odd case where you go down with a file and you just cannot get it to go through the apex, cannot get it through to the apex, cannot get it through to the apex, and basically stressing. And in those cases, I have a good chat with the patient. We decide whether or not we're going to come back, whether or not we're going to refer on to a specialist, or whether or not they just are happy for me to, to obturate. And I'm talking probably 1 mil of, from the apex. And almost always, if I've spent time with the laser, lo and behold, there's a sealer puff that comes out through the side of the tooth at that point. And I have to say that's a nice feeling when that happens as well, because at least you know that you have been down there and actually you have been getting irrigation, in that area you've not been able to instrument.
Yeah.
Cool.
Yeah, very cool.
Yeah. Because people have been, toying with, I remember going, it was a British Dental Association conference probably in, I want to say it was probably about 2002, 2003. People were talking about lasers and stuff then. And I remember Steve Buchanan laughing because he said, I can do more with my bleach, than the people with the lasers and stuff. But they've obviously come a long way, haven't they, with stuff? I mean,
yeah, do you know what I think's changed? I think the protocols have changed because obviously, as I say, there are dentists out there that are not using any form of irrigants whatsoever other than water. And I get it because obviously, bleach is not a nice, substance, is it? For me at the moment, I think that I'm more comfortable with using, bleach and EDTA. I think, as I say, it's tried and tested. It works. It seems to work very nicely in terms of follow-ups and things. And I think the biggest issue, as I say, with the lasers is I don't think you quite appreciate how much easier the endo is using it. Because all of a sudden, a lot of the issues that you would spend hours and hours and hours on. I mean, and another example, I'm lucky actually because I've not snapped any night ties, but I had a stainless steel instrument fracture about 6 months ago, and you curse, don't you? And it just felt it, and it went snap, and I was like, oh, do you know what? This is now it's another hour, isn't it? Probably I'm going to now need to take to to get this thing out. And I thought, oh, water lazed over. I am not kidding. 8 seconds later, the thing flew up out of the canal and went up the suction. I was like, oh, do you know what? I'm so happy now. I'm so happy. And it's just because literally I hadn't wound it in. Literally, it just loosened it up and it came straight back out. I was like, that's cool. And you know what? There's the really annoying bit. I had the microscope, the camera turned off on as well, and I love that as as a video to have. But anyway,
money well spent, isn't it?
But the guys using the water, basically what's happening is you're getting enough energy into the water, so it's becoming antibacterial. It's the energy, the cavitation, the energy release is breaking down the bacteria.
Yes, and obviously there's going to be bacteria have got water in them as well. So you are going to get an interaction on that front too. So yeah, I mean, it's and then obviously you're using the diode to go down. The penetration of the diode, because again, the diode laser, because the chromophores off, you're not going to get absorption in hydroxyapatite. So if you put a diode laser down inside a root canal, it is not going to get absorbed in the tooth structure. So your penetration of energy is actually better because of that. So this energy is going to go through the tooth until it meets something where it can interact with. Now, obviously, you're hoping that's going to be, the pigmentation in the bacteria. The bacteria then die because basically you've dosed them with, diode energy. And actually, then there's that whole photobiomodulation thing, that you're actually stimulating healing on the outside of the tooth by doing it as well. So as I say, I'm not doing that just yet, but I do think there's a rationale behind basically to do that. I think the hardest bit about endo is actually proving any of this is really difficult. And I don't know about you guys, but actually I'm actually using this cone beam CT scanner an awful lot more than I ever have done. And the number of lesions on adjacent teeth that I was going to do an endo on, it's insane. And actually, I've got a CBCT. I took a CBCT for the 6. I get it back, and there's an area on the 4. I get the PA of the pre-operative PA that I had up before, and I look at it, and I look at it, and I look at it, and there's no area on that periapical whatsoever. But on the cone beam CT, there absolutely is an area on it, and that's the problem with endo, isn't it? Like literally, we're trying to judge things on a, there's very few criteria that actually basically really locks down the success rates, I think. So definitely interesting though. But yeah, the laser has completely revolutionized how I approach endo, and actually dentistry, and dentistry. Pulp caps it's amazing for as well, because you can access the tooth with the laser. You can clean out the pulp tissue that you want to with the laser, but everything's very sterile. So when because obviously the whole thing about the pulp therapy is you do not want bacteria going in there. The bacteria, the laser itself is actually is antibacterial, and it's also going to it improves the hemostasis too. So it goes really nicely. And then on the back of the new generation of file systems, we are going skinnier and skinnier and skinnier with preps, which means that we're starting to breach some of the traditional rules. The academies, we're supposed to go bigger to make sure that we're getting bleach down to the apex. I think we do need additional technology to help us basically deliver bleach down to basically the apex. And the other thing about the water laser is it does produce quite a lot of negative pressure down at the apex. So a little bit like the endovac is a very safe way of getting bleach down to the bottom. Because obviously, if you're just using a syringe, it's really you're always running that balance, aren't you, of how deep do I put this needle into the root canal? I need to put it deep enough to clean it, but I don't want to put it too deep that I end up pushing it all out through the apex. Whereas the negative pressure type systems, they're quite like the endovac. It's getting it down there, but it's not so risky. And the laser actually does create quite a lot of negative. So that vapor lock, it's not an issue with the water laser. It's turning things over so much that basically, it's clearing out. You notice a lot of when you get confluence of canals, like up in premolars and things. I'll do the prep. I've measured the joining point, and everything's looking great. GPs look great. Put the laser down. The amount of debris that comes up the other canal with the laser, again, it's insane. You just think, I've had files down there that literally I did not expect to see that much debris come up. Or I've even had cases where I've thought that there might be joining, but I just can't get. When you inject your hypochlorite in and the other canal fills up, and then you suck it back out and it dries back out, and then you push it back in and it fills up, then you suck it back out and it sucks out. I've got joining canals that don't want to do that. You run the laser through, and all of a sudden, basically, that then happens. And I've got quite a few good videos. That's one of the presentations I'm going to do, in London in November. That how much better that the laser is at actually cleaning that junction out.
Wow. So can I ask how much does one of these lasers cost then, Rob?
So I think the water laser was 47,000, and the diode, I think the total bill for both lasers is about 60 grand. Okay. So it's a lot of money if you're only using it for one purpose.
Exactly.
And it's a lot of money if you're only cleaning root canals out with it, to be fair. But actually, it's so much more of a machine than that. So it's a lot of money. I mean, I don't know how much is General Wave is something similar, isn't it? Yeah, but General Wave can only do one thing.
Yeah.
So it's a lot of pennies. It is a lot of pennies. Would I? I think you can kind of judge basically your purchases based on whether if someone took them away from you, you'd be upset or not. And
that was my next question. Yeah, that was my next question.
Yeah. 100%. Would I buy another one? Definitely, 100%. Is it a fragile piece of equipment? Yes. It has to be looked after, really well. Every single component on it is expensive. So I make sure it's part of the duty of the laser protection officer to do it anyway. But you have to basically take there's a little gold mirror in the handpiece. You've got to periodically take that out, make sure there's no watermarks on it, because if we're not careful, it starts burning basically holes in the gold. Now the little gold mirror, that's like £400. If you burn that out, the energy then has to go somewhere. So you then start burning the trunk cable out. I think that's like £3,500. So if you buy one, you have it's not just a piece of equipment that you basically just you can't abuse it. You have to basically make sure it's well looked after. All the lenses are nice and clean, etc. Cost per endo about 20 quid-ish tip, single use. So it's not nothing.
And the water you put in, is it distilled water? Tap
Distilled,
water?
just RO water.
Okay, yeah. Yeah.
Wow.
Gosh.
So,
That's amazing.
Yeah, it is, isn't it?
I want to have a little. You have to do some videos for it, so we can put on the Facebook forum of of that cleaning. If you can ever get anything, it'd be amazing to see it.
Yeah.
Of course, no problem at all. I'd say the other thing about the law today as well, the tips are very flexible. So you've got the sonic activation, like the endo activator. That's fantastic because you can get it right down inside the canals, can't you? And on the other hand, you've got the ultrasonics, which definitely clean better. Because I've got all three. I did used to use the endo activator. I then got an Ultra X, which I then use a combination between the two. So if it was a central incisor, I quite like the ultrasonic. But if it was a posterior tooth, I quite like the endo activator because you just can't get that tip to go down. Whereas the laser, because it's got a flexible tip, it's like all the advantages of an ultrasonic, but you don't have the disadvantages that you don't have to worry about that tip binding on a wall and actually all of a sudden not actually doing anything whatsoever. So, and I still use everything else. I mean, I still use long neck rose heads. I still use ultrasonics. I mean, it is not the only piece of endo equipment, but it makes the job a lot easier.
But obviously you're prepping to a 3004, which I like on the OGSF. I think it's a really nice shape. It's sensible because it's sort of wide enough but conservative, isn't it, at the same time? Does it have to be prepped to a particular size then for your laser tip?
If you want, it's a 20 is the tip. Okay. The RFT2, there's an RFT2 and an RFT3, and they're a 20 and a 30. Okay,
so you can be relatively skinny still, can't you?
You can be really skinny. But then again, do you need to be? Because it's how far do you actually, as I said to you, the acoustic streaming doesn't actually work that well at the tip. The laser needs a little bit of space around it. So if you pop the laser in, it actually starts to get very exciting in terms of bubbles, water coming out when it's about halfway up. So if you're right down at the apex, it doesn't really look like an awful lot's happening. You start to drag the laser tip up out the back of the tooth, and all of a sudden it's splatting on your mirror, because all the energy's, it's shooting up out the tooth instead. So you don't have to. I mean, sometimes if it's a really tight canal, I do use the Coltines, curved platforms. That's a 2005. So that is quite small. I'm definitely more comfortable finishing on a 2005 if I've had an RFT2, laser tip down there to make sure it's washed out.
Yeah. Can I move on to something slightly different? I don't want to keep you all day, obviously, but then you'd mentioned before about bioceramics at Simply Endo. Are you obturating with bioceramics now?
Yeah, I do. I don't think there's anything wrong with AH+. I just think in some regards these finer tapers, I think, lend themselves better to bioceramics. So there's still the odd case where I'd use a backfill. If it's a big palatal canal, I will. But you can't actually generate that much. You can't get those tips in that far into these narrow preps. So I'm not really sure how much vertical downpack we're actually doing anyway. And it's quicker, isn't it? The bioceramics are definitely faster.
Do you have a preference? I don't want to put you on the spot.
I use the high flow. High flow one. So I used high flow for a bit. I then went on to Neosealer for a bit. So one of the batches was a little bit thick, and I don't know. I just didn't feel like it was quite flowable enough. So I've actually gone back onto the high flow BC sealer from I think Optident. I think it's from Optident now. But they're selling it.
total fill and high flow. That's what you use, isn't it? It's
Yeah.
been around a long time, a reasonable length of time now, hasn't it? And I do think that's where people have to be careful with the bioceramics. I think because they're under this umbrella of bioceramics, some of them are quite different, aren't they?
Oh,
and I think people have to be quite careful about what they're picking and choosing. I think they need stuff that's been around a reasonable length of time and got some evidence to back it up, and certainly the total fill.
It was 2002, wasn't it?
And BioRoot, they seem to be the ones, don't they, that have that evidence, I think. And I remember going to a conference, I think it was about 2016, it was British Endo conference down in London, and at that we were told they were the two then, the BioRoot and the high flow, well, it was total fill rather, that they were the two then that were recommended. And it still appears to be the case, doesn't it? Yeah. But I'm still an age pluser, I'm afraid.
But I don't think there's anything wrong with it. Although I still think the bioceramics, if you're not careful, you definitely send more out of the apex. I'm still think that because of the way you use AH plus, you put it sparingly within the canal. You then put the GP cone in, which then blocks off basically your apex, and then you vertically compact into it. I still see the benefit of that as well. So I don't think I'm a true bioceramic convert. I just think it works quite nicely in my treatment flow, and the preps have got skinnier, and I'm quite comfortable that the post-op's looking good. And there's quite a lot of other, specialists using this. They've used it for a long time now. So I don't think there's not one that's right. Well, more than the other, is there really? It's what we take out.
Oh yeah, all getting good outcomes, isn't it?
Yeah, definitely. Yeah, Rob, just want to thank you so much for your time. Really enjoyed chatting to you.
Blown away.
Normally me and Dave are waiting away in these, and we haven't said a lot because we've just been interested in listening and taking it all in. So it's been fantastic. Yeah, it's great to see you doing so well. Obviously, we loved having you at Simply Endo, but we see you a lot on Instagram and see you growing is just fantastic, and the work you're producing is beautiful. Really high level standards. So it's fantastic to see that, and obviously you get into the teaching side of it as well, which is good fun.
Thank you guys. Sorry, have I talked too much?
No.
Brilliant.
Oh, I see.
You're still awake, which is good.